The imaging features that you mentioned are all important for predicting the prognosis of HCC. However, among those imaging features, enhancement pattern analysis is the key for predicting prognosis, because arterial phase enhancement pattern, so-called rim arterial phase enhancement pattern, targetoid enhancement pattern, and also very low enhancement of the tumor on hepatobiliary phase imaging are the key imaging features predict bad prognosis. So I think although the tumor shape, tumor margin are important prognostic features, the most important imaging feature to predict prognosis is the enhancement pattern. As you know, in recent years, transarterial radioembolization treatment, or SBRT, are more commonly used for treating HCC. With the previous LIRAD version 2017, there was only single classification system regardless of type of local regional treatment. But that system had a limitation in evaluating treatment response after radiation-based local regional treatment. But with this new version of LIRAD TRA, we can better evaluate treatment response of HCC after radiation-based treatment. I think it works quite nicely, but the current limitation of this system would be a bit of lower inter-observer agreement. We need to improve inter-reader agreement a little bit more. And also, I think we need to further incorporate tumor marker changes in addition to imaging-based temporal changes to improve inter-reader agreement level, and also readers' diagnostic confidence level, and also earlier prediction of viable tumor detection. I think both imaging modalities are key players for diagnosis of HCC and also follow-up after local regional treatment for HCC. Whenever CT fails to make a definite diagnosis, MR could play an important role for establishing diagnosis. Furthermore, when it comes to intrahepatic HCC staging workup, MRI, including diffusion-weighted imaging or hepatobiliary phase imaging, may provide a higher sensitivity for detecting small size HCC. Therefore, in patients who are surgical candidates, we routinely use both CT and MR for staging. For accurate intrahepatic tumor staging, we use MR. For extrahepatic staging, we use CT. In a context of follow-up, we tend to alternate CT and MR because each imaging modality has strengths and weaknesses. So we try to alternate CT and MR as a follow-up tool. In our hospital, 2 times of CT and 1 time of MR would be fairly routine in a follow-up setting after curative treatments.
Okay.
So the most critical factor to determine local recurrence after local regional treatment, especially thermal ablation treatment, including microwave ablation and RF ablation, is to creation of sufficient peritumoral safety margin. At least 5 millimeter up to 10 millimeter would be ideal for reducing the local recurrence rate. If we use no-touch technique, it is beneficiary to create a safety margin larger than 1 centimeter. So basically, it contributes for lowering local recurrence by creating larger than 1 centimeter safety margin. And also, theoretically, as no-touch technique doesn't puncture the tumor, it inherently eliminate any risk of tumor seeding. So if patients is eligible for liver transplantation, I would love to use a no-touch technique, especially for the tumors located in subcapsular portion. In the future, we hope we can have more validation studies, especially in a multi-center setting, and then with the high quality, high evidence follow-up data, probably we can incorporate this kind of a technique in our HCC management guideline. I think if you understand imaging-based predictive biomarkers and risk stratification of post-treatment recurrence, maybe we can we can use this kind of information for selecting treatment. For example, if early stage HCC, like a 3 centimeter HCC, showing poor prognostic imaging patterns like LIDAR, the M imaging features, or irregular tumor margin, or very low hepatobiliary phase enhancement, maybe we can choose a surgical resection rather than ablation. And also, even if you do the surgery, maybe anatomical resection rather than non-anatomical resection would be beneficiary to reduce the post-treatment recurrence. And also, when you consider TARE versus TAC, if a tumor shows more aggressive imaging features, maybe TARE would be more beneficiary than TAC. So you can use this kind of information for selecting treatment. And also, this kind of information could be considered when clinicians to consider adjuvant treatment necessity. If tumor shows very bad prognostic imaging features, after surgical resection, the patients may consider to receive post-operative adjuvant therapy, but it requires further validation studies. So AI and radiomics are important cornerstones for imaging-based research. The current problem of these tools would be reproducibility. In imaging field, there are quite diverse imaging protocols and many diverse vendors to produce machines. So in order to produce high quality research result, we need to have a standardization in terms of imaging protocol, imaging techniques, and also reconstruction technologies. If we have a standardized protocol and techniques in imaging, next step would be creation of fully automatic tumor segmentation and also automatic detection of the lesions, which can contribute for reducing inter-reader variation. So with that kind of development, maybe we can use AI or radiomics studies for predicting prognosis of HCC. I believe we need to wait a few more years to see this kind of radiomics tools or AI tools becoming clinical tools. I think the standardization is the key to adopt these tools in our clinical practice. In the future, with the standardization effort and also development of AI tools, we can do we can produce more valuable data from imaging studies. Okay?